we avoided was to use the parallel structures which will work against the health services delivery system. So find that the implementation of the whole project was within the national health services delivery system, whereby our role was to strengthen the capacity of those structures from the community level to the district level. But also as a nation, we're implementing what we call the decentralization policy. So the decentralization policy encourages the communities at the village level to make or to demand the needs for the services for themselves. So the project was integrated within the systems which are there, and our role was just to strengthen them and even provided the resources, which by virtue of winding up the project, the systems are already there in place, but the addition is that they have been strengthened and they're able to do their work and know their roles and responsibilities well, which ensures that the activities or the progress which the project has made will continue using the existing structures.
Just to add that for us, we will continue training teachers for rural areas together with the Ministry of Education. Therefore, our students, after their graduation, also they commit themselves to do activities about malaria in the communities. So as a school, it will continue to be there. And then those teachers and the school director, they've made agreements to commit themselves to continue with the activity about malaria in their community.
Thanks. I have one last question for all of you before then I open it up to the audience to step up to the mic and ask your own questions. But building on Evaristo's last point, arguably, community ownership leads to more successful programs. How has your project found this to be true? Has your project found this to be true? And if so, what strategies or activities do you implement to ensure community ownership of the project?
So when we have started the projects, first of all, we had to make sure that our strategy is part of the national policy. And then on our national strategic plan, there is also the line called Communication for Behavior Change. And then the school itself, strategically, it's indicated as a good example how to approach the schools and the communities. So we have made these specific agreements with the municipal level, so that those group of teachers, those local authorities that we have trained, they will continue the link with the authorities. As I said, our school for training of teachers will continue. So the ownership of the project also, it will be on this sense that the connection between the schools and the teacher with the community, the activity of malaria will continue. And also we have, as a good consequence of the project, we have elected as the president of the National Forum of Malaria. So again, ADBP has a responsibility in the province to coordinate all the activity about HIV/AIDS or about malaria. And one of the examples is that we have developed tools also, like a book for manual for teacher, and also manual for students and for authorities. And then the government, the Ministry of Health, decided to launch those manuals as a national tools. It means that from now it will be used also for other NGOs as a good experience how to work with the schools.
Ensuring this malaria community program ownership of the community, you know, it was known that the government owns this program, but the community didn't. What we did was for the community to own the program. That's why we trained religious leaders. That's why we trained community health extension workers. That's why we trained school teachers, students. We found, you know, we established anti-malaria drama clubs. Also youth associations and the women associations. These all groups, attended different trainings. And now, as I said earlier, when they see the result, what this MCP program brought about, they are initiated by the result, by the outcome. Because of that, now they said, it is not government's program, it is not USAID program, it is not PMI's program, it is our program. It saves our life. We will continue. We will own it. We will find resources to continue. And this is what community ownership means. So that's why they signed a memorandum of understanding with our organization to continue. We gave them the training, we gave them some supply, equipment for, IEC and the behavioral change communication program, and now they have everything, they have every tools, they can continue by themselves. And so the community ownership is there in regard to MCP program. Thank you.
Yeah, on additional to that, the component of supervision is what actually has been making sense to make the program to keep on going. The supervision of the community health workers, whatever. They are owning the program, community health workers, the religious leaders, but if supervision is lacking, it becomes a problem. Now, knowing that, we advocated this to the district medical officers, and for our case, in this financial year, all the districts which we have been working with, they have included in their budget the component of supportive supervision to the community health workers. So this, it will continue motivating the community health workers and other community stakeholders to keep on working on the community interventions. Thank you.
And in addition to that, and in terms of the ownership, I could really agree with you and appreciate that the projects targeted the places or the areas where we had high cases of malaria. So the project was ideal for the place where it has been implemented in Malawi. Hence, communities participated very well and also seen the fruits of the project, and that has made them believe that the activities has to continue, whether we are there or not. But what they indicated was that the project was meant for them, and it's them who have seen the changes which has happened over the years, rather than possibly the project staff who worked as the machinery to move the information to the community. So the project was addressing one of the major health challenges within Malawi, which is malaria. So that made the communities to own the overall of the activities, and yes, at this moment we are celebrating that it has brought significant change in their life in terms of their health delivery system. Thank you.
Well, I'd like to take a few minutes and open it up to the audience for any questions. But after that, we invite you to a reception and to take a look at all the posters that each of the grantees have put together. So if you have any questions, please step up.
It's great to hear all of your experiences. I'm Jean Capps, a consultant, and I wrote 2 of the MCP grants that eventually were awarded. And I have worked in malaria in all of your countries. I'd like you to address the impact or influence that commodities or lack of commodities had on your projects, knowing that in most cases you were not responsible for the commodities. They were coming from government or from somewhere else, another partner. And if that had any influence on your results, and that includes nets and drugs and RDTs.
A very good question. In our MCP program, we are educating people. We are creating demand, but we are not supplying nets or IRS, anything. In the first year of our program, that was a problem. You know, we taught the people and we educate them, and we are addressing the importance of ITN, but there was no ITN there. And the people are asking, okay, you educated us, you taught us, and where is ITN? And it was really a program. But we do have a good relationship with the government and we are with other service providers like UNICEF and ICAP International in Ethiopia. And we have discussed with them, and we have a malaria consortium at the country level, and we try to address this problem, especially in our targeted area. You know, the government gave priority because the people are crying. You know, just we understand that the mosquito is going to kill us, but we don't have the net. And if this is also a concern for the government, and automatically they try to respond it after the second year of our program, that problem is not anymore a challenge. Thank you.
Yeah, apart from various NGOs which are receiving funds from PMI, the government of Tanzania also is a recipient of PMI funds. So on every month we have a meeting of all PMI partners who are working on malaria. So this issue, as my colleague said, it also arose in Tanzania. But because we have this meeting on a monthly basis, we addressed it, and it came clearly that some other partners who were supplying other commodities, they also take serious initiative. Like the government, in collaboration with other PMI partners, they are involved on the mass badness distribution in the country. That was the second year of MCP implementations. So as per now, every household is covered with enough badness according to their sleeping sites. The same applied to the SP drugs for IPT. Also, there's another PMI partner in collaboration with the government. They're also taking serious measures to make sure that we have the adequate supply of SP drugs. So the collaboration of PMI partners within the country is really helping. It helps us to get out of the mess. Yeah.
Yeah, in addition, advocacy with the government agency that is responsible to bringing ED supplies is one of the key activities that we are engaged with the National Malaria Control Program. We know when we were doing the community case management where we need a RDT, we need an ACT, we need a glove which are provided by the government. We work with those people that are responsible for the supply chain, make sure that we document every activities at the community level, show the needs that these resources, these commodities are needed at the community level. Once you document properly and you can prove your case, then, of course, those that are responsible will be willing to listen to you and help to provide. We have problems with net distribution in the community that we work. There was net distributed, but did not cover all the community, but we have provided health education, we have provided the need, and the people, we provided the demand, and the people are requesting us. So we have to take the government representative to those areas, and the beneficiary have to talk to them directly and ask for what they need. So when the request is coming directly from the beneficiary, they see the need, and sometimes they can act, because it's not only PMR net that were in the country, there was also global fund net that were in the country that were diverted to other places. But making your case and doing your documentation can help to solve some of those problems, but it's always there. You just have to advocate and work harder to work with the system to straighten it, then that will help to alleviate some of the problems that we face when it comes to shortage of this commodity in the country.
Okay, thank you for the question. I think for our case, we are running an integrated project, but our main focus has been capacity building, though we have an element of commodity supply that is long-lasting insecticide-treated net, which is being provided to children under 1 year and pregnant women. So this is a continuous process, and you know, in our national malaria control strategy is running from 2010 to 2017. So the first phase has just ended, that is preparing the ground for actual commodity provision. So, and based on to this phase evaluation, the malaria prevalence has gone down, and now we are in the phase that is running from 2013 to 2015, where we are going to deal much more with the commodity provision, where we are going to work much more on the provision of ACT and RDT and making sure that microscopy is also running alongside. So based on to that, we have realized the reduction in malaria prevalence as per se in our country, Kenya. So thank you.
In our province, for example, it's, we face some challenge. Zaire province, where we had the project, is one of the most affected by the war. And the health facilities were destroyed. The human resource is very low. And then we had to use our network with the other organizations, with the government, so that they can cover other necessary things to be done in the province, which is not part of the project. For example, we had to make advocacy so that the Ministry of Health sent facilitator to train the health staff in the health centers in the provinces. And also at that time, we have mobilized a lot of people, but the distance to the health centers, it's too much. And then people also, they don't used to go to the hospitals. Because of this poor service, they lose confidence to the services. And that was in 2009 when we started. But after our mobilization, also they increased the number of cases notified in the clinic. It means that more people, they start to use the clinics, and also increase the number of people who is using mosquito nets. So it was also then the government starts to gain confidence on the projects. And then just last year, they have made the impact stats about the project. And then they can see that the number of notified cases increased, and also the death of malaria reduced. I think no deaths, no pregnant women died about malaria in the last 2 years in the province. So it means that it's, and also we were pushing the company who is doing like the oil exploration in the province to push them for their social responsibilities. And then they started to do something. We pushed the other small NGOs that just they can do the work in the community together with us. And then it was very important to reinforce the community response. And at the same time, it's not just about mobilization, but also about how to improve the services together with the Ministry of Health.
Okay, yeah. Thank you very much, consultant, for the question. We have noted in the implementation of this MCP project in Uganda that when you create demand, there is need to match that demand created with availability of services. The MCP project in Uganda was not mandated to supply insecticide-treated nets, but after sensitizing the community, creating demand, they went to the health facilities, and sometimes they find the nets are not there. They would take their children, after referring them, they find the ACTs are out of stock. So it sort of caused a problem to the project. But we kept on engaging the community through community meetings and through different meetings to ensure that if the nets are not there, the government or the other partner who is supposed to supply us not, you should be able to save something and buy it on your own. Or another partner called Nomad was supposed to supply the nets, but unfortunately their term expired and they closed. So we had about a year when we did not have the nets being supplied. Even when they were still there, the supply were inconsistent, and even in very small quantities. So we have noted and we have recommended it in our end of project evaluation report that in future interventions, there is need to match the demand that we are going to create with availability of the supplies if the health gains that we want to see are really to be realized. So the supplies which were inconsistent sort of watered down our achievement, but all the same, the project did all it could, and the results are pretty impressive. So that has been, I think, a key sticking issue that needed to be addressed. So we were thinking if MCHIP was given the mandate to create demand and supply these nets and ACTs, I think the achievement could have been better. So supplies remains a very key challenge that needs to be taken into account, I think, in future interventions of similar programs. Thank you.
Question. Hi, Leo Ryan from the MCHIP project, and I'd like to first thank you all for coming and being on this panel. I think this is an incredible opportunity that we have to really learn from the field, and it's been very exciting to hear about the different accomplishments. A lot of the things that you've talked about, that you've done, I think are things that line up very well with some of the priority areas that we've been trying to advance in MCHIP and that USAID has been trying to advance: country ownership, community involvement, all those kinds of things. The question, I really want to take advantage of you all being here and get your honest opinions, answers to this question, which is one that I wonder about a lot. And if we think about the PMI initiative and the idea to have national malaria control programs and to have national level programs with lots of different partners involved to make it all work at the national level, the thing I wonder about is what is, and you're all working for NGO organizations, right, and PVO organizations, what is the value added that an NGO brings to that process? Like, why should NGOs be involved? Why shouldn't there just be a bunch of other partners? You know, many of you said, well, the global fund's there, and you know, there's lots of big bilateral programs and things like that. So what's so special about NGOs? What do NGOs and PVOs do? What do they offer in this kind of program that nobody else could offer? And I just like that from your experience and you know, your long histories of working in the field. Thank you.
Yeah, thank you very much. We know that the National Malaria Control is there in the country and they are responsible to take care of these activities. But most of the time they have a lot of other activities that overshadow those community engagement that they need to do, so their focus is mostly at the national level, and there at the community level where things are happening are mostly neglected. Theoretically, they were decentralized, but you won't see the effect at the community level. So what the NGO does is we work directly with the beneficiary at the community level and trying to build the capacity of the National Malaria Control Program. And the results that we get at the community level are brought to the National Malaria Steering Committee meetings. And these result in our activities and our successes and challenges can help to direct the strategies of the National Malaria Control Program. So we are there to augment their effort as long as we are working in the policy of the government. Thank you.
For the country like Angola, it will take some time before the government take over the whole responsibilities about health. Right now, it's because the national program right now is more about the policy and the orientation about the health system, about the police. But the community health system, still that is a specialty for NGOs. This to approach the families, the people, the households. I think it will continue to be a specialty for the NGOs. Right now, we have started 2 years ago what we call the revitalization of health system, where the government has responsibility about training of human resource, constructing and reconstructing new health centers, and the civil society has responsibility about the community mobilization or mobilization for communication for behavior change. So this will be speciality for NGOs during some years. And this is what I can say is a specialty for NGOs. But to make it sustainable, it will be on this way that is complementary efforts of what the government is doing and what the civil society is supposed to do.
Yeah, thank you. In Uganda, the NGOs don't work alone. They work in close collaboration with the Ministry of Health Structures, the Malaria Control Program. So they assist the efforts of the government. So in a sense, the NGOs are more on the ground. Most of them, they work at the local level and they engage the community members more closely. And because sort of they are small in size, their interventions are much more focused and their results can easily be seen. They work together with the Malaria Control Program so that their policies are in line with the strategic control, the Malaria Control Program of the Ministry of Health. So there is still need for the local governments to be there. You know, the government at times is too large. If they are to be given to run the programs entirely, at times they might not have the time because of competing interest. Others have to go for meetings. You come to the health centers, the staffing is not enough. So we need this local, the NGOs to fill in the gap. But if the system was to be very efficient, as he said, then it would be much more better to work through the government system. But in our country, in Uganda, and I think in most other countries, the system is not all that very strong. For example, in our country, especially in northern Uganda, the staffing level in some facilities is only at 30%. So if it is this health worker who is supposed to see clients coming, this same health worker is supposed to go and mobilize, go and participate in community meetings, nobody will be there to see the clients. So that's why the NGO at this time are still very important to fill in the gap and work together with the Ministry of Health and then all those established structures to see that the services they're providing of the recommended quality and consistent with the national plans for such specific interventions.
But also, in addition to that, the existence of the NGOs within the implementation of the malaria activities acts as a cross-checking or cross-examination of whatever the policies are there in terms of national malaria control program. So that we find that they have got good policies at the national level, but you go to the communities, they are not aware of that. So the implementation or the translation of that policy into action, most of them is done by the NGOs, because you find that sometimes there's a conflict of interest among the health workers to translate the policy into implementation at the community level. So existence of the NGOs made it that the communities are aware of the policies which the government is promoting, but also demand for such services which they will get it from the health services delivery system. But also I should agree with the previous speakers that most of the countries, you find that the health worker to population, the ratio is just too big. Hence, there's now a need to concentrate more efforts on the communities themselves to take responsibility of the